So inpatient alcohol detox, and again, these are services that are going to be fewer and far between, so harder for people to be referred to them. GP referrals will probably help. So supporting that, speaking to the GPs where we can get notes updated is really critical, even if they don't stay there. ADFAM, they provide a list of charities and private organisations that can help people recovering and families and community. It's quite a specialist area, or to get the appropriate support. So you get a lot of people that may go into prison, they won't necessarily get the medication because they don't always have the staff that can administer the mental health medication. A lot of the prisons are run by private firms. And that's one of the key things that I find when I'm delivering training in prison. Those are some of the things that people are saying. NHS, you can go onto their websites and you can actually put a search in. And if you type in your postcode, it brings up support that is in your area for various different things. So diversionary model, child-centered approach, together for mental health. Again, all the links are there. Go and check out the websites of these people, because they will become some of the tools that you use in terms of making sure people get the right and appropriate support. They have a 4-step model of support. So they say seeing the whole person. So remember, we talked about the social elements, not just the person that's there sat in front of you, but actually all the things that are going to be impacting. Compassionate inquiry, so person-centered approach in ways that they are doing, and doing it together. So potentially a more motivational interviewing style, where we're actually speaking with the person and we're actually getting from them what they want, and we're working with that to formulate a plan and planning for the future. When young people are thinking about the future, they are potentially filled with hope, or there is some element of hope. If they are not planning for the future, we should be concerned, because quite often when hope is gone, suicide becomes an option for them. Motivational interviewing, link there. On the About Us tab, there is a very, very useful short video, and it just gives you a really succinct exploration of what it is, what it does. It's used a lot now or by social workers with young people in terms of their interviewing. It's also used a lot in terms of bipolar. But yeah, it's a 4-step model, and it's a person-centered model way of working. Trauma-informed, building resilience, emotional intelligence. Some of those things are quite often missing. So again, types of treatment, counselling, our service provides that. We also provide advocacy. A lot of people that leave the trust and still need support come to us as well. EMDR, someone mentioned that last week. So eye movement, desensitization. So this again is your 4.1. We are describing the management and treatment of approaches that can be used in terms of addressing mental ill health. Helps you to process that trauma and recover from past experiences that may be affecting your mental health and well-being. Your psychiatric decision unit, or voluntary or involuntary treatment. So spaces, 136 units are when you are maybe detained there without your sort of knowledge. But actually sometimes you can, if you're known to a service, go back and go into that service on a voluntary basis. So basically you're saying, I'm feeling like I need a bit of support. I want to come in for that support to be provided. So that means they actually have a right. They probably might have more freedom in terms of leave, in terms of going home in the community, and they will be supported while they are maybe staying in that service, but maybe having home visits as well. Psychologists, they can diagnose, and what they are doing in certain places or services is upskilling some of the nurses just in terms of some of the things that they can prescribe. So they can diagnose mental health, provide that psychological intervention for recovery, but also third sector organisations are really, really important. So when I say third sector organisations, organisation like ACT, CIC, our organisation, organisations that aren't necessarily funded directly from local government, but we may get some bids, some servicing in terms of funding from the lottery and various other spaces as well. So thinking about why treatment opportunities are missed, key one is mistrust of services. Some of that links back when you think of like the Black communities, BAME communities. Sometimes it's a mistrust of services or maybe a past experience. We said not being signed up to basic health services, such as a GP or dentist. Some of the young people may have been like taken off a list because they've not maybe engaged with the service for 2 or 3 years, and that might be an issue as well. Professionals maybe don't always recognise the signs of gangs and youth violence, so are not maybe looking out when we go to a GP surgery. How it works with GPs is that they sit on a professional register. They must have a minimum amount of continued professional development each year. But my experience of working within GP surgeries is that doctors will specialise in the things that interest them, so they don't have to do a lot more in mental health. They don't have to do anything on gangs and youth violence. If it's a special interest for them, then they will. So what's useful is to maybe when you are contacting a surgery, just ask whether or not people specialise within a certain area, and that might be where you get the best support. Young people might not identify that they maybe have a need that needs to be met. So I think it was you, Elizabeth, that talked about a group of friends or people that you knew that don't actually recognise unwellness or don't actually recognise mental health. So where culture plays a part in that, or whether a lack of insight for someone plays a part of that, that's really important, because the sooner we get treatment, the better in terms of the outcomes, in terms of recovery. Living in the wrong postcode area might also be a key factor. When we think of specialism around things like eating disorders, they're quite specialist and not many are available. So you might have to go more to the private centres like the Priory. But services like that might not be available to someone in Birmingham. What that then means is that they might then get transferred out of Birmingham to another county, and that might mean that the support that they would normally get, the visits that they would normally get, would be minimised. That could also be a factor why someone might disengage from a service and not want to remain there, because it's a protective factor. The support that you get when you are unwell from family, loved ones, that is helpful, is classed as a protective factor, okay? So the need for the service may not be meeting the threshold for engagement. So I think I mentioned last session, the Good Child Report, Nikki, and then I will...
Sorry, I couldn't get off mute. I was just saying as well, what I've found recently is even when I've contacted GPs on behalf of people, if they've had previous substance misuse,
they
tend to just dismiss it. It's drug-related psychosis. And I'm sort of saying, yeah, but we're testing them and that they're not using drugs at all, and they haven't for quite a significant period. But they're still, it's almost like they don't want to know sometimes because they've had that history of substance misuse. They just want to kind of push it to one side. And kind of blanket it as that as well.
I think sometimes it can be the attitude of practitioners. So when we think about gangs and youth violence, I don't think I've ever come across a GP. In fact, no. My GP surgery is Laurie Pike. They have a partnership with, I think it's Birmingham University, and they train the GPs and doctors. But Dr. Elizabeth England, she does a lot around mental health. So they are very in the know and aware of mental health, because one of their doctors at the surgery specializes in it and they train. So because they train people, those are the sorts of things that they actually encourage them to look out for and be aware of as well. I did a lot of work with an organization in Stratford Mind. So Mind, it was almost like a franchise of Mind, the larger. But the services were just like totally different. So they used a product that was a legacy product, and we looked at 7 different areas: depression, anxiety, loneliness, and delivered specific programs that aren't delivered in the mainstream of Mind, but actually their awareness in terms of gangs and youth violence was minimal. Their services are quite minimal as well. I worked in a GP surgery, and it was literally this building on a car park, and that was their facility for mental health. So what they often do is they might see someone there, then say, oh, we can't support you, you need to go to Birmingham, and then refer in to Birmingham. So the lack of services, just dependent on where you live, can be one of the factors that feeds into not getting the support that you need. That's fine. So policies maybe need to be reviewed. I was actually this morning at an event by an organisation called Catalyst for Change. We work quite closely with them just in terms of the local mental health trust. And they've got this new initiative, it's been in the making for a number of years, but actually how they are embedding the Equality Act and the responsiveness of culture and race in terms of the services. It's got to the point now where the CQC are actually embedding it in terms of how they will go out and monitor people to make sure that people's cultural needs are also being met. It's looking at the restraints within services. So if you aren't aware, if you type in Seni's Law, it will give you a bit of information. Seni Alasu, he was an African young man who died in the custody of the police when they came to support around mental health. But it was, again, in terms of restraint. So Seni's Law basically dictates that when people are in services, it kind of links into the least restrictive practice. So restraint should always be that last resort rather than the first point of call. And how many restraints, etc., all those sorts of things should be being monitored within services. So trauma-informed or trauma-informed care, trauma-informed practice. An organisation, a London-based organisation, did a TIP report, trauma-informed practice. They were commissioned with some doctors to do some research around trauma and gangs. They delivered it online because COVID kicked in. So if you can Google that, the TIP report, really, really useful. So trauma-informed care is an approach where we might ask, what has happened to you as opposed to what is wrong with you? So we're not defining people by, oh, someone with depression. You may have a diagnosis, but you might be living with. Quite often people say that they don't like the feeling of being defined. But today's learning outcomes, we're going to identify the different individuals and agencies working in the field of mental health. And we're going to also list the implications of medical and mental health issues. So when we talk about medical, think about the physical. Someone's been involved in an incident, stabbing, shooting. What might the medical implications be? Then we're going to be looking at the mental health issues and the appropriate agencies to address them. So if someone is maybe a victim of that perpetrated crime, what might be the implications from a mental health point of view if they are then starting to deal with that? We've just recapped from last week. So think about the mental health issues just in relation to that. Who are the agencies that may be able to address them? We're also going to be looking at 5.3. We're going to explain the roles. So you've got to go into just a bit of detail just around explaining the roles and the functions of individuals. So what is their role? What do they do when they are implementing that role? For the individuals and professionals and agencies that are working in that field. So you've got your 3 elements there: the individual person, the professional, and what they might be doing, but also the agency as a whole. What might the agency as a whole be doing? So 5.4 is again to explain how agencies work in partnership to support an individual's mental well-being and or illness. So on these ones, what I will be doing is just having a chat with you guys, and when I'm asking for examples, you can maybe start linking how agencies or the type of agencies you actually work with in partnership when you're supporting young people. If your organization needs to get someone involved, what does that relationship look like? What need might you trying to be meeting for that young person? And how do you actually work in collaboration? So that one's really, really important. Okay. We're also going to be analysing the procedures of a chosen organisation working with an individual with mental health. So we're going to look in detail at maybe one or two specific organisations, because you'll need to choose one that you want to focus on for your assignment. We're also going to explain processes to work with individuals from different ethnic groups. So I think it was objective 3.3, we sort of looked at how some people might be impacted more than others. For this one, we're going to be looking at individuals from different ethnic groups. So again, we're looking at culture, we're looking at all those sorts of elements and the different types of things we might do to ensure that people can receive the services, be involved. And when we think of Equality Act, that they can actually get involved and not be unable to access the service. We're also going to be looking at describing the legislation relating to mental health. So looking at a few bits around that when we start 6. And then we're going to explain the responsibilities of the individuals in relation to current legislation. We've looked slightly at legislation at the start. We defined mental health. We looked at the main piece of legislation linked with mental health sections. We looked at sections and places of safety. And for your final criterion, we're going to explain and understand policies, procedures relating to mental health. So when we think of legislation, we're maybe talking about what's been passed by local government. Once we start looking at policies and procedures, the Mental Health Act, for example, might then start to be broken down, and key bits of that legislation will be embedded into our policies and procedures. Or give you an example, Health and Safety at Work Act. If we look at that when it comes down helps us with our safeguarding policies, our health and safety policies at work. So looking at how the legislation then impacts the policies and procedures that we put in place. So we may put procedures in place and ways of doing things so that we can safeguard people under the Children's Act, which is linked to safeguarding. All right. 5.1, individuals and agencies working in the field of mental health. Okay, so individuals, got a list here. So we've said psychologists. I
think a GP is probably the first port of call for a lot of people, isn't it?
Yeah, well, it should be, but I think I hear a lot that, I didn't bother going to the GP because you just can never get an appointment. I think sometimes there's a deterrent because they've maybe tried to get help there before and it's not worked. Should always be though, because even if they don't do anything there and then, normally they will update notes, and those notes will provide a bit of background when it comes to eventually making an assessment around mental health. So frequent contact with the GP so that notes can be updated are going to be quite useful in terms of maybe formulating a diagnosis for someone. And agencies, we've said CAMHS, we've talked about Aquarius. Third sector organisations like ACT, CIC, ourselves, we get a lot of people that have maybe gone to CAMHS, been told they aren't sick enough to actually access the services, and they've come to us here. I mentioned Birmingham Solihull Mental Health Trust. They are actually at a 20% deficit in terms of the staff that they need to provide all the services, and they're doing a lot of collaborative working to enable local organisations like ours to be able to provide some of those wraparound services, because they're struggling at the moment, struggling with recruitment, just in terms of retention. So maybe high turnover of staff for whatever reasons. And Rethink organisation, probably one of the key organisations in terms of being able to understand mental health and legislation. They do lots of bite-size PDFs on the different sections, so section 2, section 3, section 1, 3, 5, 6, those sorts of things. We've mentioned places of safety. So
Nice.
places of safety, a number of years ago, when someone was unwell with their mental health, they would be able to go to a police station, and that cell would be what they would consider to be a safe place. There'd been a number of deaths in police custody. There's been a lot of change and outcomes through coroner's verdicts. So it's now that police stations are no longer places of safety. So primarily, if police come into contact with someone who is unwell with their mental health, the ideal place for them to be is a section 135 suite. So they will take them to a place that is specially built, where people will maybe be under observation for 72 hours, put under a section 2 to have like that 28-day assessment, and that would be considered a place of safety. Yeah, so when we think of the implications of medical and mental health issues, so potentially substance abuse leading to the physical health implications, we looked at that. Remember a caller in the video, he talked about, you know, diet, your liver, when it had toxins, and why people do those detoxes and cleanse their systems, drink a lot of water, not drink alcohol, change their diet to kind of manage those sorts of things. So physical health, so you've mentioned stabbings, hospital, outpatients, GP surgeries. So lots in terms of people. Do we think about housing when we think of gangs and youth violence? Do we maybe think about housing and that maybe being impacted by mental health at all?
Yeah, we've got a lot of young people that sofa surf, that haven't got a permanent home.
Yeah, so there are different levels of homelessness, isn't there? Someone sofa surfing might not be considered homeless, but actually if you do not have a permanent place to lay your head, that's potentially causing you a lot of distress. And we deliver the violence and aggression against women and girls and the implications in relation to homelessness. You'd be surprised at the way people mask, and why maybe a young person's car, if they've got a car, might be so much of an attachment for them, because potentially that could double up as their home. But I've got Kia. Do you want to?
Yeah, why does that fall under medical?
So with housing, why I've put it there is that I've had lots of experience with my brother. He's diagnosed with bipolar, and one of the key things that sorts of happens is when he becomes really unwell, potentially manic, he tends to listen to a lot of like ragga music, really loud banging music. He's nearly been evicted so many times, and that then has quite an impact on him in terms of his mental health. We wouldn't ordinarily think housing, but actually the threat of being homelessness or homeless is quite an impact. That's why it's there, because I support people, and it's not something that we ordinarily will think about in the immediacy. So in terms of when we think of medical, housing might be one of the agencies that will get involved, if that makes sense. He's unwell with his mental health, but actually housing, so his housing officer understanding his mental health condition, that he's got a disability is really, really important. That might link into the social worker, so that agency there would be your local authority. Your housing coach might be the housing association or local authority if they are the home. Does that make sense?
Yeah, it makes sense. I just think because it says medical, I automatically think like hospitals, GPs, things like that, opposed to. Thank you.
So that's one of the agencies that would maybe help to address part of the medical sort of implications. The mental health element is their thought pattern. So remember, we've talked about CBT as one of the things to address. So what you might say if we're talking about that cognitive behavioral framework is that they've got maladaptive thought processes, or how they're processing their thought patterns is not normal. So there's maybe an error in the way that they are thinking about things. And how that might translate is that he has maybe processed that maybe eating, then bringing all that food up, or whatever he does to cope is the best way of coping, rather than maybe thinking, right, let me learn some new skills, let me talk to someone about it. Those are the societally acceptable things that we would ordinarily do to try and cope with something, learn new skills to try and address it. But in this case, they respond in a certain way. And if we think about adults, I've had like, I think it was she was a head teacher of a school, similar sort of, there was a lot going on. I think there was a divorce, just running the school, and exactly what you said, this young person said it was the only thing that she felt able to control, and that was how the eating disorder developed. Mental health, we've mentioned about disabilities, minimum a 12-month period where whatever you are experiencing in terms of mental health has been debilitating in terms of your life, so having some impact on your day-to-day life. And we would say with something like depression or anxiety, it would become a disorder when it starts to impact your day-to-day life. So it's not just you're experiencing anxiety, it might be that you are diagnosed with general anxiety disorder. Mental health work, how might your job or a job loss impact your mental health? 2018, after the financial crisis, I think it was Derby University and is it Nottingham? There were a couple of universities, they did some research, and you know, each year the ONS sort of like tracks the number of deaths, etc. They tracked to see if there were any additional deaths linked directly to the financial crisis. And what they found was there was 10,000 additional deaths, so on top of the people that would normally die within a year, or the period that they did the research for, and that was directly linked to redundancy, debt, and home repossession. So those three factors were the direct causes for those 10,000 additional deaths in that 2018 piece of research. So job loss is really, really, really crucial. When you think about the amount of social interaction you might get, whether it's going on the bus, commuting, stopping off at the shop, socializing with your work colleagues, when that's taken away, so a lot of people can become quite isolated. Education, how might that be linked to your mental health?
I worked with young people that couldn't read or write. So when they came into the prison, they had to do an assessment, and they were traumatized the fact that they had to fill in an assessment. So what we tried to do is, rather, because we had to do it in a group, we had no choice. I would just say that I fill this form in every single day. So I will come and sit with everybody because I'll be quick. And that way I wasn't singling anybody out that couldn't read or write. And it's just offering sometimes when I deliver the mental health first aid training and there are case studies to read out, I tend to check with the group, and it doesn't single anyone out, and it gives people the option, and we tend to go with the majority. So can you see that we've got housing over here as well? So how might housing also be linked to that mental health, and what might the implications? Think of the organisation NACRO. Are you familiar with NACRO? What do they do? Who do they tend to support?
I worked very closely with NACRO within the prisons, so they supported a lot of our guys that were being released homeless, helping them to even just get them registered with the local councils, and linking them in with provision that could support them into accommodation. So yeah, lots of difference, and even sustaining tenancies. And fighting the corner as well.
You will find private housing associations potentially won't even go near someone. I mean, when you think of some of the things my brother, we're talking when he was like really becoming unwell, burnt down his flat. The fact that we've maintained this tenancy, he's had this for so long now, and it's because he's really maybe adjusted to him having a diagnosis and maybe accepts it more. But it can be a lot of work, and private, if you think about the housing crisis and the need for housing, a lot of private tenants won't even touch people that are maybe on benefits. But if they can't get a really good reference, they won't go. So imagine the mental health implications for that as well, not being able to find a home. So yeah, lots of things there. So implications and medical and mental health issues and the appropriate agencies to address them. So 5.3, individuals and professionals working in the field of mental health. Kind of gone through quite a bit. We've mentioned psychologists, mental health advocates, volunteers, students on placement. So you might find, I know Aston University is a feeder university for, you know, the IAPT service that the NHS runs. So people go on to do that IAPT course, improving access to psychological treatments. They go on to that course for a year. When they are on that course, their placement is Birmingham Solihull Mental Health Trust, and they actually start to implement the work within that trust under the psychologists. Students on placement, we utilise students on placement. We've got close connections with BCU, Birmingham City University. We've got 4 volunteers that are supporting us with our counselling services, and just developing some community services locally. But we've always worked with volunteers, and what we do is we help to upskill them. They get access to all our training. So again, individuals, anything else you can think of in terms of individuals? So individuals, again, working with professionals. We're just going to go into a bit more detail on some of them. We've mentioned psychiatrists, so this is the one that we're kind of pulling out. I've just generally gone through and pulled out a few examples. So psychiatry is the branch of medicine that they actually deal in. It deals with the origin, so why someone may have become unwell, the diagnosis, so if they've been diagnosed with bipolar, schizophrenia, prevention, so they may be advised and set up treatment plans on how you can prevent it maybe escalating, and also the management of the mental health disorder that has maybe been diagnosed. They can actually advise around the emotional, so we've talked about the emotions. Some people are quite driven by emotions or quite overwhelming. That could lead to, we talked earlier about the young person with the eating disorder, potentially feeling out of control and using that to maybe have something to feel in control of. Behavioural disturbances, we've talked about the paranoia, mania, so when someone's maybe quite elated. So they're trained as a medical doctor. They also receive further training in that field of diagnosing and managing those illnesses and disturbances. So someone like me could be a counsellor. I mentioned that Aston University, they do the course that then qualifies you to go on and be like then an IAPT professional within the trust. So that's on the psychological spectrum. So you have to go and have specific training. It's a minimum standard of training. So specific, and it enables you to get onto a register in turn. I think it's the CAB register.
The roles and responsibilities might include planning, delivering services. We say high quality services. Think about how high quality services might change when we think about staff shortages. So independent mental health advocates, their role, advocates are independent of the NHS and social services. How it normally works with our local trust is that, you're right, Scott. Okay.
Sorry, my laptop's dying and the charger's broken.
No worries, no worries.
Sorry.
How it normally works is the trust will buy in a service. I know it had been Power. I'm not sure if they are still the advocacy service that are in. So they buy in that service, and this external service will provide the advocacy for someone who is maybe within that mental health facility. So it's not someone that works directly for the NHS. I would say it's almost like, you know, when an employer pays for an EAP service, an employee assistance program, they fund it, but they don't necessarily disclose the information back to the mental health trust. The advocate is basically independent of the trust, and they are able to advocate and ensure that the person they are supporting gets their needs met. Individuals and professionals working in the field of mental health, approved mental health professionals. So we're going to watch a video on that now. So remember the guy that was doing the talk, he said, you know, the police may stay if we assess that like the risk is there and they need to keep people safe. Quite often police are there to kind of take control of a patient if they maybe become quite ambivalent, maybe violent, and protect staff. Staff should be trained in some sort of therapeutic management of supporting violence and aggression in a therapeutic way. So NHS clinical commissioning groups, I will actually pop the article I was discussing because I think that will be quite useful if anyone wants to read it. So NHS clinical commissioning groups responsible for the planning and commissioning of healthcare services in their local area. So sometimes you might find that someone is maybe in Birmingham, or someone from Birmingham is sent to Wales or somewhere because there might be a specialist unit down there, but actually the budget may come from Birmingham or the clinical commissioning groups that are linked to the person and where they get their funding from. They may pay for that facility down there. Made up of GPs, including nurses, secondary care consultants, and lay members. So lay members may be retired GPs, just people within the community. Some stats on some of the funding. So when we think of funding, that funding will cover things like how much it costs to care for one person for a week each day, or when they are in a facility. It might mean that part of that budget will be, if a normal NHS facility is full, they may need to pay for them to go into a private facility like the Priory, which would probably cost a lot more. So all those sorts of things will be factored in. Do you think that 79.9 billion in 2019-20 is a lot? So again, we're meeting criteria 5.4, joint commissioning. So we're thinking about how people are collaborating and what they do to work together. Mental health, the most underfunded sort of like team. So yeah, Solihull Metropolitan Borough Council, Birmingham Council, joint commissioning teams, they aim to improve mental health of local people. Sometimes they can be exacerbated, but this is where your advocates can come in to try and advocate. And it's horrible to say, sometimes it's the people that do have someone fighting their corner that get the care that they need, and others are left by the wayside because they are maybe too unwell to say, you know, I know what my rights are and I am not going to accept this. Or they just give up because they're just sick of saying, sick of fighting. Healthcare such as most planned hospital care, rehabilitative care. So again, this is linking into the medical implications as well as the mental health implications. urgent and emergency care, including out of hours. I think when you were talking about like going to the hospital being handcuffed, that will still happen in Birmingham. If they are handcuffed, it's potentially because while they've maybe been out and unwell in the community, they've maybe done something which they could potentially be arrested for. That's where the handcuffs will come in. Once they get to the team, and I think it's the RAID team at our local hospital, Dudley Road Hospital, they will do like a triage and just assess them. And if they assess that they need an AMP assessment, that's when the ball starts rolling. So they aren't just taken straight to a place of safety. When the street triage was in place and they were taken from the street, they would normally be going direct to a place of safety first. But where they were maybe overloaded, they would still have to go to the hospitals, and they have now removed street triage. So yeah, mental health services, Mary Seacole is quite local, Oliester is quite local, Rayside Forensic Unit, and there should be a single point of access, which is it Forward Thinking Birmingham, which is like the main sort of like place for young people to kind of get their referrals through. So partnership working. Police may arrest someone and determine that they are a risk to themselves or a member of the public. So we're covering 6.2 in terms of meeting criteria. A section is put in place under the Mental Health Act to detain them from a public place. So that's your section 136, to keep you or take you to a place of safety where you may get an AMP assessment. Your section 135 would allow them to maybe take you from your home if you were at home. So you call the ambulance service. So think about how all these things now interlink in terms of collaborative working. Street triage is now disbanded. The police are now saying we will not attend if it's mental health. So what's going to happen is someone will be distressed, they will assault someone, then a phone call will be made and they will say, right, someone's been assaulted, and then police will go out to an assault rather than supporting a team around mental health. Salisha?
What was street triage, or is that what you just described? Sorry.
It was a service where they would have an unmarked vehicle with a police officer, a mental health nurse, and an ambulance technician. So when someone dialed 999, if you told them that they were unwell with their mental health, they would send the street triage team out. It actually led to a 0 death rate in terms of police custody. They have disbanded it. I think tail end of last year it was disbanded. We'll see. It was formed out of a number of families losing loved ones. So Kingsley Burrell, Mikey Lloyd Powell, our family friend who died in police custody, and it were recommendations from the inquest that there should be something like this in place, and it actually reduced the number of deaths within Birmingham. So although deaths in custody were still happening up and down the country, it reduced it to 0 in Birmingham. Yeah.
Why did they disband it?
Costs. That's what we've been saying. It's budgets. Mental health is probably the most underfunded area in the NHS. Yeah. So yeah, we've had a look at the video in terms of the Oliester. And before using that section 136, they must consult a registered medical practitioner. So an officer would normally have to radio, stay in touch with someone, a registered nurse. That was why the street triage team helped, because when you had the officer going out, they already had that mental health practitioner there. So yeah, it makes no sense, but finance-wise, it makes sense to the people with the budgets. So once under that section 136, then maybe based at the Oliester, you may be supported by one of those professionals. Your nearest relative believes that you can be cared for with the support of your family. They now want to apply to discharge you from that Mental Health Act, so they may want to remove that section 3. Section 3 might be in place for up to
is it 90 days? They could detain you, and while they are detaining you, they are assessing you, just in terms of your mental health. Potentially sometimes, Nikki says we utilise street triage a fair bit. It's really missed, yeah. You know, when it seems to make no sense, but it's a cost thing, isn't it? Sometimes a date might be set for a tribunal. I've actually sat in on a tribunal as well, where the person whose section can give evidence as to why they think they should be released from their section. They might say, I'm responding well to the meds, my mum or my family can support me. Remember the term least restrictive practice? Those are the sorts of things they will consider. So you'd normally have the tribunal judge, which is normally like a doctor or psychologist, someone who is qualified. They will have lay people, which may be some GPs, people that maybe support with the courts. They still take place online sometimes, but sometimes face-to-face as well. Evidence can be heard from the family. They can say, we've got the capacity to support our loved one, we want them home. And professionals might say, well, although they've got this support, we maybe need more time to assess them. So we want it to stay in place for now. So those are the sorts of things that can happen in terms of partnership working. People will work, and partnerships can include family members and the person that is being placed under a section. So, yeah. So the section 3, it's normally 90 days. They would normally have to extend it. So they would have to apply for an extension if they felt they couldn't fully determine what was wrong, or maybe someone might not be responding to the medication, and what they might be doing is changing the medication and see if something else works better or they respond better to a new or different medication. So they could renew it, but actually if 6 months came, what they would potentially do is families might start saying, well, no, we want them home, and that's where the tribunals might kick in. Connection with other organisations and partnerships. Consortiums, Living Well Consortium is our local consortium. They tend to get a bulk of the work through the NHS. So they become like almost a single point of access, and it's a number of organisations. I know Patigift is an organisation that provides counselling, but they do it from an African-centred perspective. Citizen Coaching, another organisation that I know is part of that consortium. A colleague of mine, Marcia, forget her name, she's a director or a trustee of an organisation called WAITS, Women Acting in Today's Society. So a number of those people sit on that consortium panel, and they may get large sorts of like bids. They basically are able to bid for larger bits of funding in terms of procurement. So getting services delivered by community groups and organisations that have maybe bid for it and say, we will deliver that service for the NHS. Networking, referrals, so you may have organisations, so ACT might refer someone to us in terms of their mental health. I might refer someone to ACT in terms of if they've come to us and we identify that maybe gangs and youth violence is maybe playing a part. So those sorts of things. Criminal injury compensation scheme, and they can support people to make a financial claim for compensation after an injury caused through a criminal act. Yeah, so again, just lots. Process to work with different individuals from ethnic groups. What might we be doing in terms of processes, putting things in place to work with people that are maybe from different groups? What sorts of barriers might you face?
Language barriers.
Language barriers. So what might we do or need to put in place to be responsive to that?
Translators.
Yeah, translators. It's, if we think about the Equality Act, if we think about the Mental Health Act and them actually being able to consent, no one's going to be able to consent if they've got any sort of capacity, if they don't understand. So that might be something in terms of their rights not being breached. So Joint Commissioning Panel for Mental Health, guidance for commissioners of mental health services for people from the Black and minority ethnic groups. Was it Justin Varney? He works for local authority. He did a lot of online sort of like talks in terms of trying to appease communities when COVID was happening. The number of deaths in terms of Black, Asian, minority or ethnic groups due to COVID-19 was just astronomical. 10 key messages are the equitable access. Commissioners should address ethnic inequalities in mental health, implement specific measures to reduce those inequalities. So we're talking about marginalisation. You've done marginalisation. We know it means there are going to be layers and layers of potential intersectionality, all the different things that increase barriers for people, which maybe leave them at a disadvantage. Developing strategies for improving mental health and well-being among the BME groups. Targeted investment in public interventions for BME communities, involving service users. So when we're thinking of a trauma-informed approach, a person-centered way of working, that should be the case, but isn't always the case. And we know that's not the case when funding is an issue. 20% deficit at the moment in terms of the staff needed to run the services and the staff that they've got for our local trust, Birmingham Solihull Mental Health Trust, who are the largest mental health trust. Commissioners should ensure that service providers collect, analyse and report and act upon that data, particularly around ethnicity. So they should be collecting data, doing evaluation and actually adapting and being responsive in terms of the services that they are putting out based on what the data is telling them. That's what they should be doing. Create more accessible, broader, flexible care pathways and integrate care services or services across the voluntary community. So organisations like ours, third sector, social care, health sectors. Key things funders like the lottery will not do. They will not provide services. For example, if we said we wanted to put in a bid because we want to run an alternative provision because the schools are just not doing well enough, they wouldn't fund that. They don't fund anything that should be provided as a statutory service by the local authority. We can say we want to provide counselling, we want to provide support, and this is why. But what we can't do is replace the NHS service and say, I'm going to specifically deliver the services just to the NHS people because they've got a 20% deficit. They wouldn't fund it. Every mental health service should be culturally capable. And, you know, when we think about culture, the BME or BAME groups are often meant a key sort of focus, but think about people that are from maybe Romani, Gypsy groups as well, you know, so potentially they don't have fixed abode in terms of a house. They are quite marginalised within communities as well. When people come over because they've migrated, we've said that's acculturation. So different ethnic groups, and we get migrants come from all over the world. We're thinking about the process to work with individuals from different ethnic groups. This was something, so again, all the links are in the presentation at the end, so you can go and do a bit more sort of like reading. This news article, King's College London, excess deaths in people with mental health conditions increased during the COVID-19 pandemic. So more robust assessing could address that, including around race, pregnancy, underlying health conditions and extra cleaning. Extra cleaning was one of the most basic things. I actually blew the whistle during COVID because that was not being done, even though people were dying. And, you know, it might seem like a simple thing, but COVID was not just like the flu. People were dying from it left, right and centre. Yeah, and it was highly transmittable. So yeah, more robust practices. So thinking about legislation relating to mental health, someone choose a piece of legislation and just let's have a discussion about it. Come on, no one's going home until we do. Coronavirus Act.
there's a lot going on at the moment in the news. Is anyone watching the inquiry, looking at the updates? So Coronavirus Act, I mentioned in session 1, during COVID-19 and when we had like the pandemic, they changed the Mental Health Act, and it meant that where you would have the AMP assessment, there was sometimes one practitioner, one person that was making that assessment, and that was a variation to the Coronavirus Act because of COVID-19. So imagine if someone maybe didn't have the cultural awareness and they were the sole person doing that assessment, and how that might impact someone. So lots of legislation. Human rights is a key factor, because when you are detained, you have your rights taken away. The Doles Act, Salisha?
I mean, I don't know much about the Human Rights Act, but I'm just noticing there the date 1998.
Yeah.
Is there anything that relates to mental health that you think needs updating? Because that's like obviously 25 years old.
What they would have had, I think they would have had like amendments. Do you remember the lady talked about like when the Mental Health Act was amended? So what they don't do, you have the original act, and then when they amend it, it becomes Human Rights Act 1998, and then it will almost have a subsection where it says amendment, and then it will have the new year that an amendment was done. So that's just the original act. Does that make sense? So there will have been updates to this act, but they will be classed as Human Rights Act, and it will say the amendment, the year of the amendment, and it will detail what that amendment was. Again, the reference for that will take you to legislation.gov.uk. That will, if you type in the name of any specific acts, it will bring up the acts, and it will also bring you updated. So you see there where I've said Mental Health Act 1983, updated 2007. So that was probably linked to where they made the update in terms of who could be an AMP assessor, because it used to be an approved social worker. It's now an approved mental health practitioner. So sometimes they might be a social worker, sometimes they might be an occupational therapist, a counsellor, someone who's had additional training to do that assessment. Does that make sense, Salisha?
Yep, that's good to know.
Yeah. Okay. So 5.5, analysing the procedure of a chosen organisation working with an individual of mental health. BU Not, so they're a Nottingham service. Again, all the links are in there. So some of the things that they do in terms of analysing the service, they provide youth centres, pupil inclusion projects. So they try to include people rather than exclude them. Street-based work, outreach, as we might know it, or mentoring. Emotional health, Cardiff Youth Services, response to emotional health is supporting young people, colleagues, schools and other professionals to identify healthy coping strategies to minimise the need for support or specialist support from mental health. So quite often I was saying it's that we need to learn new skills to actually cope with maybe changes, bereavement, really impacting life events. So that's some of the things that that organisation does. So what do? They offer a range of services, adult, children's services, and for young people. So free one-to-one counselling around mental health, emotional well-being, free group therapy, free online counselling with Kooth. My understanding of Kooth is that people buy into the service, so it's not all over England. Certain mental health trust or local authorities may buy it in, and once it's bought in, they will maybe provide either online Kooth or a variation, just dependent on the level of what they've paid for. Blues Project from Action for Children is really good, 13 to 19-year-old, Scott says. Scott, that might be an organisation, if you know about their services, that you can use to answer this question and analyse their procedures. What do they do as an organisation when working with an individual, and maybe just describe some of the things that they do when they're working with people around mental health, and the services they provide. Okay. Explain processes to work with an individual with mental health. So we've said one-to-one counselling. Not everyone will want one-to-one counselling. They don't want to feel that it's about them, that there's something wrong with them. Group therapy may be better. Some people might not want to talk about how they feel, what's been happening in front of other people. Using play to self-manage their emotions, arts, crafts, young people drawing can be very useful. There's an online tool by Dr. forget the doctor's name, but it's an online sand tray, really useful resource. We use it online, and it's almost like if you're doing any sort of work with a proper physical sand tray, it's an online version. So if you're supporting online, they can choose their characters, they can choose like different backgrounds, themes, items, and you can do that therapeutic work. It gives you the option to save it, and then you can download it as a PDF and actually save a copy of the work that's been done. So explain processes to work with an individual with mental health. I've just explained how you could use an online sand tray with someone just to explore their feelings, dynamics at home, certain situations, issues around abuse, what's happening in home. So individuals and professionals working in the field of mental health. We've talked about that in some detail, but these are some of the people that are specific to this organisation, BU, NOTS. So again, we've kind of gone through that in terms of our NHS, looking at it in more clinical sort of view, but we're now looking at third sector organisations and what that alternative support might look like. When you're looking at answering those criteria. So explain the process to work with individuals from a different ethnic group. Professionals from this agency work directly with the communities. They access the community in places often known as hard to reach. Normally not hard to reach. You tend to know where people are. It's whether or not you want to actually go there and provide the support. They only provide a service online. So they might not capture a lot of people out in the community. So what you might need to do is choose an alternative organisation that is maybe culturally aware and actually put services in place to meet cultural needs. Or you might actually start to develop training for the community and think of ways that they can then access it. Again, explain processes. 5.6 we're responding to here. This organisation lacked any real acknowledgement in their website to address any different ethnic groups or diversity as a whole. You might want to contact organisations. So this organisation here, Hope Nottingham, they do have an equality, diversity and inclusion on their website. You may want to contact them to find out how they actually do work with ethnic groups. Sometimes it will take a culturally sensitive organisation like ACT or ours to work with certain types. I'll give you an example. I support a client who came to us who is based in Solihull. They are from an Asian background, and some of the issues they went to support with were around honour-based abuse. They were told from the statutory service that they couldn't deal with those issues. So sometimes our statutory services don't have the skill set in their staff. So what you might need to do is recruit to make sure that you are able to meet the needs of the people you're supporting. So again, just another couple of examples. It might be useful for you to think about the people that you actually work in partnership with, do that collaborative working, and think about how you're going to apply it to them and the work that you do. This organisation said they had outcome-based support. So previous outcomes from evaluation, they would then put services in place based on what people were saying they needed, or the therapeutic sort of like improvement. They also said they work with small teams. So
a more person-centered approach rather than a one-size-fits-all, and they are actually a disability confident employer. So if you are working with someone from a gangs and youth violence background, and they may be on the spectrum in terms of special educational needs, it might be looking out for a disability confident employer, but also thinking whether or not they've got the gang specialism, or thinking whether or not you need more than one organisation to start supporting that young person. Any questions or just general input around these criteria that we're sort of like explaining and going through? Everyone wants to get home, okay. Mind, so Mind are probably the most well-known national organisation. I mentioned that they can sometimes work almost like a franchise. Community development workers, so this is how they work with different individuals. So professionals from this agency work directly with communities. They actually go into the communities in those hard to reach places. They attend local community venues, social events. So you might go to a local event and they would have a stall there and they would be giving out their leaflets. They develop training specific to communities, so culturally sensitive, and they actually recruit as well to meet the needs. So, for example, they may recruit a Somali worker to engage with the community because they know that there's maybe a high uptake in terms of people that maybe use the facilities from that ethnic background. Any other ways we could work with people to address those cultural needs? No? Residential care.
I don't know as well. Like I always like, if you don't know, try and find out, especially like if it is completely new to you. I think it's important for your own sort of like, let's get to know this sort of demographic of people and how, or you know, let's reach out to like people in work and see if they can help.
It often costs money though. That's the only thing we've said, just how important a budget is. And quite often when people, maybe even when they go to third sector organisations and the budget runs out or the project ends, then that's the end of care. One of the key things that we do as an organisation is when we take people on in terms of our counselling, Salisha said she agrees with Elizabeth, is that even when the funding runs out, we will have people that we are still delivering services to, because we won't just say, right, funding stopped. And that's why we use volunteers as well, because we're able to continue those services. Because I mean, the impact of just stopping services and saying, right, yeah, that's it, money's run out, we can't do anymore, it could be life changing. And that's something we don't do. I've got a client, I know a colleague's got a client that came to us during COVID when we were funded by the lottery. That program ended, but because they were on that program, what we've said is, if you ever need to come back to us, then come back to us and we will look at negotiating our fees so they don't pay anything near what anyone else would, because they've been on a project that was free back in 2020 when we were funded. We put those things in place just to ensure that people can afford to consider their mental health well-being, because quite often people don't access it because they can't afford it. That's it shouldn't be a choice between having to like feed your family and getting your psychological help if you're not getting the service you need from statutory services. That's why we practice the way that we do. Prison leavers turn to us. St Giles, is it Ingeus, do a lot of like support around prison leavers, therapeutic support, training, all sorts of stuff. Bernardo's and Nottingham befriending service, so lots and lots. I think so. 6.1. So describing the legislation relating to mental health, we're thinking about 6.1 now. We've looked at the Mental Health Act. We've looked at sectioning under that act. Really, really good resource. Rethink. It's documented. Go back to it. Have you got any experience with ex-military? I've heard that is a big mental health issue. I do. I worked with someone So when we think of ex-military, we tend to think of people that were maybe in the Falklands War or just war. When we think of military, this person he wasn't actually a soldier that fought in the war. He actually was a contractor that would build their accommodation. So when people went out to war, he would build the accommodation, like the hospitals, the barracks, for people to stay in. But he was actually exposed to a lot of things, and some of the things he described, seeing bodies on the road, etc. So when you think of military, people do ordinarily think of people that were directly in the war in terms of going out and fighting. But actually, remember we talked about vicarious trauma, so that secondary element, people can get PTSD from that as well. But yeah, loads of legislation. They've actually implemented, the lottery have actually got specific funding on their website for ex-military services. Mental health first aid, they've actually got a product of mental health training that is specific to people that were in the military. And also a colleague of mine went and got a job. I'm trying to think which authority it was with. There's actually some new legislation that's come out where people that were ex-forces, there's a specific budget that's been implemented particularly to address their sort of like mental health needs. There's been a lot of legislative changes in the past year or so, and there are people that are specifically being recruited to find these people to deliver that training and support. We're going to jump on to, sorry, done it on the wrong screen. Describing the legislation relating to Mental Health Act. Mind, Google Mind, they will describe for you as well. Rethink Mental Health has really useful guides where you can download the PDF on Section 17 leave, responsible clinician, all those sorts of things. So definitely go and do your homework. All the links are in the presentation, and I'm going to send this updated version to Tez. So when we describe the legislation, leave, Section 17 leave, anywhere away from the ward, it has to be authorised by the doctor, so normally the responsible clinician. This is known as Section 17 leave. When you are detained under the Mental Health Act, you are not allowed to leave the ward freely. Remember we talked about that DOLS, Deprivation of Liberty Act, that DOLS, so they would have needed to apply saying this is the facility, this is what we plan to do here, and then that DOLS would have been granted. And those are the types of things that the CQC will check on when they go out. So if that DOLS has lapsed and it's not been kept up, it could mean that if they were still detaining people there, I actually worked for an organisation where that had happened. They would lock the service. We worked with young people that were on the autistic spectrum, and they would lock the facility. And when they had an inspection, that was one of the things that they found. The DOLS order hadn't been in place, so they were actually not allowing them to leave the service, and that was unlawful because that DOLS wasn't in place. So it has to be granted through the courts for it to be in place. So you guys need to now look at those legislation, think about what you want to explore, and make sure you're describing that. Explain the policies and procedures relating to mental health. Remember how we've talked about how they are cascaded down. So the safeguarding policy, who can tell me what piece of legislation might have informed that? Well, no one's going home until someone's choose something off the slide. Come on, guys, we've kind of talked through this. What piece of legislation may have influenced any of these things? Safeguarding, lone working policy, your observation policy. So your observations are when someone may be at high risk and they are on maybe a one-to-one observation, which means anywhere they go, someone will follow them. When I've been on one-to-one observations, people that are really high risk at maybe attempting to end their lives. Even when they go to the bathroom, they might need to leave the bathroom door open. You're not necessarily watching them, but you can't actually leave them alone because the risk of them harming themselves is so high. Again, These are things that have to be agreed, written into their plan to meet the law in terms of the least restrictive practice. There has to be a huge risk